Welcome back, everyone, to the Evidence-Based Hair Podcast. I'm dermatologist and hair loss specialist Dr. Jeff Donovan. I'm also the director of the Donovan Hair Academy. The Academy educates the public about hair loss, and we have training programs for hair loss practitioners as well. Hair loss affects all people around the world, and so we welcome all people to our programs. The Donovan Hair Academy runs the EBHF, or the Evidence-Based Hair Fellowship. The EBHF is the world's most comprehensive training program for hair loss specialists. Our EBHF graduates ultimately complete 2 years of very intensive training and are some of the best trained specialists in the world. The podcast that you're listening to right now is the official podcast of the Donovan Hair Academy. In this podcast, I review studies that are changing how we think about hair loss. I'll introduce them to you, help you make sense of them, and give you my thoughts on how a given study just might change how we diagnose or treat hair loss. And as a reminder, the podcast is for educational purposes and shouldn't be considered a substitute for medical advice. I very much enjoy offering the Evidence-Based Hair Podcast. I enjoy being able to join you for our public webinars throughout the year and our ever-popular Question of the Week program. But before we begin today's podcast, I'd like to add that your support really makes a difference. And I thank all those who have supported us over the years. We have some very big goals for the next 10 and 20 years, not only in our podcasts and our webinars and our Question of the Week program and our training programs for healthcare practitioners, but in our multiple tireless efforts to ensure that the principles of evidence-based medicine will always be our guide in this most perplexing and complicated world of hair loss. If you'd like to learn more about our programs and projects that we're currently fundraising for, or to make a donation, please visit the Donovan Hair Academy at donovanhairacademy.com/projects. And now on to our podcast. Today I'd like to review with you an interesting study from JAAD Case Reports in June 2024 titled Treatment of Insulin Resistance with Terzepatide Leading to Improvement of Hair Loss. A really fascinating study which documents the possibility that a new class of medications could have more relevance to androgenetic alopecia than perhaps we once thought. So this new report highlights the possibility of a diabetes drug called Terzepatide benefiting a male patient with androgenetic alopecia. Terzepatide is a novel glucose-dependent insulinotropic polypeptide and glucagon-like peptide, so-called GLP-1 receptor agonist. It's used for the management of obesity, and it's used for the management of type 2 diabetes. And we'll come back to this group of medications in just 1 minute. But let me remind you that androgenetic hair loss is frequently associated with metabolic disorders. A certain proportion of individuals with androgenetic alopecia have metabolic syndrome, high blood pressure, diabetes, insulin resistance, obesity. And previous studies have suggested a correlation between insulin resistance and hair loss, at least in some patients. But definitive mechanistic relationships are still really quite poorly understood in this area of hair loss medicine. And so this study looks at Terzepatide and, in general, medications targeting insulin resistance as potential agents to help with hair growth. Now, certainly insulin and insulin resistance is very relevant to androgenetic hair loss in a proportion of males. Some studies have failed to demonstrate significant differences in insulin resistance between males with androgenetic alopecia and controls, but certainly other studies have found a connection that a proportion of males with androgenetic alopecia are insulin resistant. And the same phenomenon exists in females as well, that metabolic syndrome is present in a proportion of females with androgenetic alopecia as well. It's not entirely clear how elevated insulin and insulin resistance would contribute to hair loss and contribute to androgenetic alopecia. Some studies have suggested that mechanisms of vasoconstriction and effects on testosterone could contribute to miniaturization, but really the mechanisms aren't well understood. And so this particular case report in JAAD Case Reports set out to document the benefits of Terzepatide, which is a glucagon-like peptide-1 receptor agonist. And the authors set out to document the effects on improving hair density in a patient with androgenetic alopecia and insulin resistance. Very, very interesting study. Let me introduce you to the patient, 57-year-old male patient with a body mass index of 33.45. He presented with a 1-year history of hair loss, as well as insulin resistance and dermatologic manifestations of insulin resistance, including acanthosis nigricans, these pigmented areas of the skin, often on the neck, as well as other areas, which are signs of insulin resistance. He didn't have diabetes. He didn't have thyroid disease. But his blood work showed that he had insulin resistance. He had a hemoglobin A1C that was normal, but he had elevated fasting insulin, and he had borderline elevated glucose, and his insulin resistance score was 3.2, with the normal being less than 2. So a 57-year-old man with elevated body mass and insulin resistance. And he was referred to endocrinology for evaluation of his insulin resistance, and he was started on Terzepatide, 2.5 milligrams every 7 days. So what are these GLP-1 agonists? Well, I think we're going to hear a lot about these, and certainly next week's episode will focus on hair loss with the GLP-1 agonists. So we'll come back to this quite a few times in our time together. But the GLP-1 agonists are a type of medication which are used for the management of type 2 diabetes, and then went on to be approved for the management of obesity. These medications work by reducing blood sugars, which help regulate metabolism in patients with insulin resistance and diabetes. There's lots of GLP-1 agonists on the market. You know them by many names. Semaglutide, like Ozempic and Rybelsus, exenatide, liraglutide, and others. The GLP-1 GIP receptor agonists are another group of closely related medications. Terzepatide is one of them, also known by the brand name Mounjaro. And Terzepatide was the focus of this particular study. Now, both Ozempic and Mounjaro work by mimicking incretin hormones. Incretin hormones are a group of hormones that are released when we eat food, and they regulate blood sugar levels and insulin secretion in the body. And the two main incretin hormones are glucagon-like peptide-1, GLP-1, and glucose-dependent insulinotropic peptide, or GIP. And so Terzepatide, or Mounjaro, goes by other names as well, is a GLP-1 GIP receptor agonist. And so this patient, this 57-year-old male, started on Terzepatide 2.5 milligrams weekly for 3 months. Then his dose was increased to 5 milligrams weekly. And within 6 months of being on Terzepatide, he experienced weight loss of 20 pounds. This remarkable weight loss that we often see with patients on these groups of medications. And he remained on 5 milligrams weekly for 6 months before moving to his final dose of 7.5 milligrams weekly. After 1 year on Terzepatide, he had lost 30 pounds and he had regrown some hair. The patient was not using any other medications for hair loss, and so it was thought that this improvement in his hair was attributed to the Terzepatide. Lab tests showed that while on Terzepatide, that his insulin resistance improved. And so do check this out. Wonderful publication in JAAD Case Reports by Emily Gordon and last author Lindsay Bordone. This is a really nice photographic documentation of this patient's hair growth with Terzepatide. It's not complete growth, but it's an improvement in density with a medication previously not thought to impact hair in this manner. I really like this case report. I think this case report is one of many types of studies in this area we will see over the next months and years ahead. It illustrates so nicely that the treatment of insulin resistance not only facilitates weight loss, but facilitates hair growth. And these findings suggest that there's a potential for these GLP-1 receptor agonists to influence hair loss. And this may, in fact, be a novel strategy for us to think about in the years ahead as we think about different mechanistic strategies to address androgenetic hair loss. I certainly think that all patients with androgenetic hair loss need blood tests. As you know, I believe that every person with any type of hair loss needs blood tests. But for androgenetic hair loss, we need CBC, TSH, ferritin, vitamin D. And because of the metabolic dysfunction that is associated with androgenetic hair loss, I am a big believer and always have been that patients need glucose, hemoglobin A1C, cholesterol, triglycerides. And I certainly think it makes sense with studies like this that we think more about insulin resistance, the HOMA score, which we'll come to in a minute, because there's no denying that a certain proportion of patients with androgenetic alopecia are insulin resistant. And I think we don't give enough thought to this. We certainly don't give enough thought to the fact that patients with androgenetic alopecia are at increased risk for metabolic dysfunction. They're at increased risk for heart attacks and strokes. The literature tells us that for the last 3 decades. Now, the HOMA, or HOMA score, is a wonderful tool. It's easy to calculate. You just need insulin and glucose. So if you have a fasting serum insulin and a fasting serum glucose, you can calculate the HOMA score. And there's a number of free calculators available online. You just Google HOMA score, and you type in your patient's insulin, and you type in your patient's glucose value, and there you get the HOMA score. A HOMA value between 0.5 and 1.4 is normal. If you're approaching 2, you're getting into insulin resistance. And a HOMA value above 2.9 is indicative of insulin resistance. And so I think the challenge here is, what do we do if the drug causes the telogen effluvium? How different this story would have been if this man, 57-year-old male, started Terzepatide and developed a telogen effluvium. And we'll talk about hair loss with GLP-1 agonists / GIP agonists next week. But what do we do in those cases? Do we change the agent? I don't think we know yet. And then how long do we need this drug for? Well, most drugs should be considered for life. We really don't have any reason to believe that any medical treatment for androgenetic alopecia would be short-term. And so if we're going to say in a case like this, Terzepatide helps androgenetic alopecia, what a great treatment, well, then you're committing the patient to a life of this particular treatment. This is a very expensive treatment. This isn't a dramatic reversal of androgenetic alopecia. It's certainly a nice improvement. But these types of improvements could have come from minoxidil, maybe, could have come from finasteride, maybe, could have come from other agents. So this study by no means suggests that Terzepatide supersedes any of the treatments that we know about. Not at all. It's just another treatment for our list. And it's an expensive treatment. And so if we can reach the same degree of improvement with a very cheap a treatment, like minoxidil or oral minoxidil, then perhaps that does make more sense. So really, to me, this study is a wonderful study in proof of principle, teaching us that these mechanisms that regulate insulin resistance are highly relevant to androgenetic alopecia. Now, these weight loss drugs are needed for life. And studies are teaching us that when patients lose weight and then go off these drugs, they gain the weight back. And certainly it's not a surprise that if patients stop these drugs and they've had benefit to their hair, we would expect that they would lose their hair. And so it's really a study of proof of principle of a class of medications that we haven't thought about before that can increase hair in some people. We don't know if this male is a 1 in 800 result. Maybe this is a miracle. You'll never see this again for 5 years. Or maybe this is typical of Terzepatide. We don't know. Good studies haven't been done. So we don't really know how commonly Terzepatide causes improvement in hair. We do know that Terzepatide and the GLP-1 agonists, semaglutide, do cause hair loss and probably have a twofold increased risk of causing hair loss than many other medications. So clearly we need more studies to understand this better. But what a wonderful study showing us a novel mechanism for a drug which is approved for the management of obesity and the management of diabetes, a drug that affects insulin resistance, that affects the pathways that promote hair growth. But remember, it's just a single patient, so it's hard to draw conclusions. But it's case reports like this which fuel further study. And I'm particularly a believer in case reports, and I'm particularly a believer that elegant case reports like this are very much needed in our field to document treatment effects, get people thinking about this, and fuel additional studies. And I think we'll be hearing a lot more about this. But clearly, further studies are needed to understand how we can impact these pathways to grow hair. Do we need injections into the body? Or can we somehow change this in a manner that allows this to be administered to the scalp? Clearly, we don't know yet. More studies are needed, and more studies are needed to compare how well a treatment like this might work compared to minoxidil, finasteride, PRP, laser. These pictures are nice, but they're not unlike anything we see in a typical day or week in the management of androgenetic hair loss. And the question that comes from this study is, well, these GLP-1 agonists and GIP agonists are super expensive. If they're approved for obesity, great. But what happens if the patient's, not approved? Well, it's a super expensive treatment. Is it possible that you could get the same outcome with an old, inexpensive, widely available drug, metformin? No one knows. But metformin also impacts these pathways affecting insulin resistance. And we're using topical metformin in the hair loss world. We're using oral metformin in the hair loss world, especially in the management of CCCA and in the management of sometimes scarring alopecia. So could metformin provide us with novel treatment strategies in androgenetic hair loss? We'll have to wait and see. I want to thank you so much for joining me today. Next week, we are back and we're going to be talking about hair loss from these GLP-1 agonists / GIP agonists. We're going to be talking about a very interesting study in the JAAD, looking at the risk of hair loss from semaglutide, as well as the risk of hair loss from Terzepatide. A very interesting study which dives into the FDA adverse events database and teaches us that maybe these medications do cause hair loss, and we need to be thinking about this. Thanks so much for joining me today. I look forward to seeing you next week. Thank you so much for joining me for today's podcast. It's my belief that education and educational endeavors like this podcast can help clinicians acquire new knowledge, which can ultimately help patients. And education can also help hair loss researchers to ask better research questions. And better research questions can give clear answers about how to best diagnose or how to best treat hair loss. And ultimately, this will see benefit in our patients with hair loss. And education can also empower patients to acquire new knowledge so that they can engage in critical discussions with their hair loss practitioners, which hopefully will lead to improved care. At the Academy, we're really proud to be able to offer educational programs for clinicians, as well as educational programs for the public. And if you're a practitioner interested in studying hair loss at an advanced level, you might consider applying to the Evidence-Based Hair Fellowship, or EBHF. This is an intense program, but it's a program that equips you with the necessary skills to really help patients. Our next iteration starts January 2026, and we'd love to have you in the program. You can learn more about the EBHF by contacting our administrators at info@donovanhairacademy.com. That's it for this week. I look forward to seeing you next week for another episode of the Evidence-Based Hair Podcast. Thanks so much.